Good evening. This is Karl Dambacher with Gold Rush News, Dambacher's Daily Debate. Again, we look at Obamacare. Tonight we have Dr. Stolp with us and John Cellucci, patient advocate, software expert. Before we get into them personally, we just need to bring you up to date some of the things you may not have known. That 65% of people did not want their health care changed, according to a current over-the-weekend report. And Gallup poll has recently reported that 56% of adults say they do not want the government responsible for their health care. So there's concerns about what is and what is not going to be available. Will we be able to keep our doctor? Can we keep our plan? So let's start it off with Dr. Stoltz. Dr. Stoltz, thank you for joining us. Give us a little bit about who you are and what you do.
I am the health officer for Tuolumne County. I came to Tuolumne County, goodness sakes, in '83 and started a family practice. For 20 years, ran a family practice, became the medical director of the MACT Indian Health Program, and 10 years ago, almost 11 now, took on the job of the health officer for the Tuolumne County Health Department.
Okay. Now, is that an affiliation with Sonora Regional in some way or another?
No. Each county, we have 58 counties and 3 city health departments in the state of California, and each county by statute must have a health officer to oversee safety net services and public health needs of communities. Okay. These are the programs. The thing about public health, Karl, is that it's typically invisible. It's something that doesn't show up unless things are going awry. If you're doing your job, people are getting vaccinated, diseases aren't showing up, food is being distributed, and people are doing well, educated. In education, transportation, all arms that contribute to health are a part of the concern for public health departments. So that is under the responsibility of the health officer, and then, of course, after 9/11, many of the emergency response requirements for counties also came under the umbrella of the health department.
Seems like a lot to do.
It is a lot, yes.
Yeah.
It is, but on the other hand, it's an exciting time. We're entering a time, as you know, based on your recognition of the need to educate the public about health reform. This is a time when health reform is critical for this country. I remember in 1978 when Ted Kennedy came to speak to our class at UCLA School of Medicine about the need for health reform. It always tickles me when people say, this just came up so quickly and it seemed to run over us like a wave. In fact, it's been worked on and considered for many, many years. So finally, unfortunately, because the problems have reached critical mass, it came time for some sort of health reform. And I gather there are certainly pluses and minuses that I'm sure we'll get into later.
Sure.
But I think that's what we need to iron out.
All right. Thanks, Dr. Stolp. John, you have a phenomenal career. So start off with just describing who you are and what you are an expert in.
Well, my name is John Cellucci. I actually lived in Tuolumne County up until just about the time you left. But I think it was 79 when I went back to San Francisco State. But I moved in the county when I got out of the Air Force in 1970 and lived in the county, went to school at Columbia College, also taught music out there part-time. Wow. And I left to move to Southern California to be closer to the production world and found myself in working in R&D, research and development for a company that had a contract with the Defense Nuclear Agency. That actually evolved into working closely with another person here locally, David Tichnell. And David and I were transferred back to the East Coast and worked with U.S. Navy SEALs doing counterterrorism assessments around the world. That was a project that lasted about 5 years.
Wow.
I wanted to move back to California, so when I moved back to California, I rejoined the electric industry, working in the IT departments, and started off just doing everything from software deployment inside of PG&E, which has about 20,000 computers on their network, to eventually I was a director of Arriva technical support for the computerized systems that the power companies use in their control centers. So in other words, PG&E has a control center that is talking to the hydroelectric power plants, the geothermal power plants, the wind power plants, and it's monitoring the generation, the transmission, the distribution, the load on the system, and they manage that in real time. So when they developed the deregulated markets with the electric industry, it was not too dissimilar from now when, and if you all will remember in 2000, the very large debacle with the state of California and the overruns of the costs of implementing electricity deregulated market in California was a huge expense with Enron and all that. But I don't want to get sidetracked here. It's just that it was an interesting time for me. From that, I was working at the California ISO in Folsom, and unfortunately I contracted meningitis. And I have stopped working since that time and have had, up until that point, really never had any major medical issues at all. Right. Unfortunately, my wife has begun experiencing grand mal seizures and has had some very serious spinal problems. She's been hospitalized 10 times in the last 3 years. So I'm here today really as a patient advocate, not because I know anything about the healthcare industry, because my experience is strictly as a patient. And the kinds of things that we have experienced dealing with the insurance companies, dealing with the doctors, dealing with the specialists, and dealing with the quagmire of carrying insurance and trying to, of course, oversee all of that and just take care of your life and have good health.
Absolutely. Dr. Stolp, now how would you just educate us a bit about your practice, or are you seeing patients now? And what is going to be the accessibility for the Affordable Care Act here in Tuolumne County? Do you have any sense of what the utilization will be, what the costs will be? Can you give us just the basics of Medi-Cal, Medicare, and how
Sure.
Obamacare fits into those two things?
In our last assessment of Tuolumne County, we saw that about half, 47% of the population is covered under employee-based insurance.
Now that's 47% of what total number? 60,000?
Of the
50,000?
This is of the, no, it's not, because I'm talking about all year long having had that insurance.
Okay.
And so it's a subset, but it's close to the 50,000 population.
Okay.
Actually, if you remove the population that's incarcerated.
Okay.
At SCC, at Sierra Conservation
Sure.
Center. So close to half, we can look at it that way. About 15% are uninsured and 20% are covered either under Medi-Cal, which is the California Medicaid program, a safety net program for those with limited incomes, and Healthy Families, which is now folded into Medi-Cal. So we can just lump that together as the Medi-Cal population. So 20% Medi-Cal, about 50% under the employee-based insurance, 15% uninsured, and a remaining about 18% or so that have various other types of coverage.
Wow. So we've got somewhere around the 30-40% that has some serious health care issues that are utilizing the system. Is that a fair number?
30 or 40% using safety net insurance and or are uninsured and or pay. Yes, I'd say so.
Now, do we have the capability to provide the services with an increased population if, in fact, Obamacare gets fully implemented? Do we have the people needed in the right places?
That's a good question. If we include, in Tuolumne County, we're quite fortunate. Actually, we just completed, under funding through the Affordable Care Act, actually, just completed the Tuolumne County Community Health Assessment.
Perfect timing.
How about that? Yeah, you called us. You called it right on the nose. It hasn't been distributed yet.
It would be a logical question, wouldn't it not, to be seen? In other words, how are we going to be impacted?
Yes, absolutely. What I was going to say is that we actually have some benefits because our population doesn't have the high non-citizen population that the rest of the state has, and non-citizenship eliminates you from being accessible to the Affordable Care Act funding. So since our population is, we have a lower number of immigrant community members, a larger percentage of our uninsured will be covered by the Affordable Care Act. Exactly. In fact, we're expecting somewhere a remaining of about 10 to 15% of our population that would be uninsured after, of the currently uninsured population that would be covered, uncovered that is. So we expect a large proportion of our population will receive coverage.
And not to digress too much, but will the reimbursements be able to cover providing of the services?
Very good question.
With an increase of
Yeah.
usage. Is that a fair thing to say?
Implicit in that question is, where is the funding going to come from, right? The idea is that there will be no increased funding for the total amount of funding that goes to healthcare in this country, which is an astronomical $2.6 trillion in the United States, up from $700 billion back in 1990. Wow. So a huge increase. I noticed in one of the earlier programs, Karl, that folks were mentioning that the percentage of that pie that was going to physicians has diminished, and the percentage going to hospitals has also slightly diminished. But when you think about the tremendous increase in the size of that pie, it represents about a fourfold increase in the money going to both hospitals and physicians. So when we ask right now, where is that money going, we have to point to all of us, including ourselves, because everyone is contributing to it. The patients, the physicians, the hospitals, the pharmaceutical industry, and very significantly the insurance companies, which was the target. So all of that is addressed in the various titles of the Affordable Care Act.
And part of it, not to digress too deeply, is are serious concerns regarding actual costs of specific things and services inside, let's say, the hospital model. In other words, is everything really being looked at per line item, like on a menu? This is, kind of each thing costs a certain amount. And are they being really looked at, not just from an insurance model, but from an actual cost standpoint?
That's also a very good question. The ideal way for this to unfold would be for those in the field, those at the front lines in the hospitals, to decide how those costs, those specific costs, are affected. The answer is no. Are the prices being fixed in certain ways? No, they're not. The funding, last time I checked, there were 46 different programs, safety net programs sponsored by the public safety net. 46 different programs. That's today. When you think about the costs of the eligibility forms, the eligibility screening, the people that need to be trained for eligibility, the grant, the funding for the buckets, the 46 different buckets, that is an extremely inefficient system. And a lot of the funding for what we hope to redirect into health care is coming from those buckets. Also, the medical loss ratio, you understand that insurance companies that used to spend about 25% of their funding on administrative costs now must spend 15 or 20%, no more, on administrative costs. Everything else is supposed to go to health care. So shifting, I think a proper way to look at this is shifting of the funds towards those locations that will be most effective and efficient. And efficiency is partly made up by gathering data to identify where the gaps are and where the needs are. So that was why this was part of it.
So if I could speak to this a little bit, because having come from the software background, and I think everything you're saying is very informative. I know that any people that will be watching this show will appreciate having a direct answer to some of these questions, as most of us do, about the funding, because the real issue for me has come down to the fact that I really don't think we're really going after fixing the real costs of the healthcare, but the way that you get there is through quantifying the information in such that you can determine and qualify the data to try and identify what part of it is it the spine problem? Is it hip replacements? Is there some element of doing medical services that makes up the bulk of the costs that are going to have to be treated by the people that are uninsurable? I mean, it seems to me that there would be a lot already existing from insurance companies who have booted people out because they're going, these are too expensive people, we can't afford them. So there's a lot of data right there that someone could look at and say, well, you know what, that's this type. Does that exist?
That's an excellent point. I brought this along just for fun. This was
what are we looking at?
We're looking at an actuarial chart from an insurance company in 1924.
This ought to be interesting.
It works. It works
24.
just as you said. Yes, we're talking about almost 100 years ago. Back then, of course, there were very few ways of measuring the quality of health. What they measured was simply sugar in the urine and protein in the urine, and they recognized that life expectancy was influenced by if you had sugar or protein in your urine. Basically, of course, identifying those patients with diabetes, for which they had minimal treatments, mind you. But the insurance companies dealt with that by simply saying, you're not insured.
Right.
We won't
Right.
cover you, or charging such an exorbitant cost to those patients because they knew their longevity was affected by this showing up of urine and protein in the urine.
Sure.
The situation evolved from from then to the point where we now have some very elegant testing and a tremendous amount of data to help the insurance companies basically set the odds wherever they like. And it's because of that, if you look at the skyline of any large city, most of the highest sky-rise buildings are going to be insurance companies.
Yes.
Yep.
They simply set their profit margins. That's the predatory practices of the insurance industry is much of what's being addressed, and hopefully we'll reshift those costs towards where it should be. After all, insurance was a cooperative arrangement to provide care to the public. It wasn't meant to be a profit-making gold mine. And so trying to see how we can do that, understanding that businesses have a right to make money and should be making money, but when we're dealing with a population that, and a situation, a health care condition that is not a commodity. It's not a television set. You don't go to the emergency rooms and say, I would like to have an appendectomy and I'd like to have a room for 3 days and IV normal saline, please.
Yeah.
Your pancreas or your appendix or your tibia is the one that makes the decision. And so that's why our healthcare system needs to be integrated and to see that we have a safety net for people. It evolved, after all, out of a disability insurance program. In the 1800s, it was the textile industry, employers that wanted to provide health care to their employees that started the insurance industry in the first place. So, and that's why we have this employee-based insurance company that we're trying to sustain.
Well, it was there to primarily be able to make sure they had healthy employees to continue working.
Absolutely.
That was the Kaiser model, because the Kaiser company started that process.
In 1945, that's exactly right. Kaiser came along and in fact set up physicians at the location of the Hoover Dam during construction. That's right.
Now, John, you have an incident, or with your wife and your family, that this really drawn your attention to the fairness of this process, and you had to go through some very extreme measures.
Yeah,
Please.
I've had
Please go
some, and you will find, by the way, I've written about several of these in my column on the Gold Rush News website, just because it was a shocker for me to go through and learn it, and the more people I talked to realized it was a shocker for them as well. And I discovered more and more that many times people that have these kinds of experiences, they're really stuck with just either having to pay the fees and not understand why, or they wind up having very severe financial circumstances as a result of it. But let me focus in on the incident we're talking about. My wife had been hospitalized at a hospital in UCLA Trauma Hospital in South LA. We were actually going to Catalina Island for the weekend. She had a seizure in the terminal, was taken there. She was in the hospital for 3 weeks. She had bleeding on the brain, was actually almost catatonic for a week. But the experience that I had at the hospital was just horrible. And I not only was keeping notes on this, but I was sending emails every day to all of the family, because when my wife stops communicating with me, I knew there was something very seriously wrong. And as a result, it turned out I had a very detailed record of what happened day by day. Well, so at the end of her stay at the hospital, the insurance company, Blue Shield, said, you need to transfer her to a facility closer. So we have some that are in network. I said, can I please have that list? And then I went out and looked at the in-network facilities and picked the one that I thought would be closest and the best for us. So that information was on a Wednesday. I conveyed that back to the hospital on a Thursday. Their discharge person said that they would probably be discharging her and transferring her on Friday. So I went home Friday night, and when I called Friday evening, they said no, she hadn't been transferred up there. So come to find out, and by the way, if you're ever in the hospital and your discharge paperwork is not done by 4 o'clock on a Friday afternoon, it's not going to happen till Monday. I'll tell you that right now. It's really hard for them to actually process people out. But as it turns out, my wife ended up staying in the hospital over the weekend, Saturday, Sunday, Monday, and Tuesday. She was transferred on Wednesday. And I thought everything was fine until 3 weeks after that, I got a bill, demand for payment for $36,000. Because Blue Shield had declined to pay those 5 days because she had been deemed ready to be discharged, which is true. She had been deemed ready to be discharged. But the hospital said they still had to take care of her for those 4 to 5 days and that I was responsible for it. Now, by the way, because she was on her way out, she was not getting any medicines. She was in a shared room with 3 other women. They had one lady who didn't speak English very well, who was monitoring all 4 women. And when you figure that out, that's about $9,000 per day for a room with no services.
Yeah.
I mean, and I got very angry about it. I went to Blue Shield and I said, I don't think this is right. And actually, I don't think you should have to pay for this because the hospital was at fault here for not transferring my wife. And they said, well, but we're still denying it. So my next course was to appeal it. I appealed that. It was also denied. And I tried to call the hospital to talk to them about it. They just didn't even want to speak to me. It's your bill, you owe it, pay it. So my last resort, which Blue Shield had put on their forms, was to contact the office of the commissioner, insurance commissioner for the state. I had done a lot of documentation on my case. I wrote it all up. I provided that information to them, and within a week, I was notified that Blue Shield was paying the bill in full. And so I have to admit, having the office of the insurance commissioner there, for me, at this point in time, and I can tell you $36,000 is a lot of money when you're sick,
Yeah.
you know, that it was, I was very, very thankful that they were there and that they resolved the case so quickly for me. But something like that, I mean, to be able to resolve that took a lot of effort on my part. Plus, I'm also dealing with my wife, who, by the way, is going through all the entire scenario, which happened about every 4 months. Of ER to ICU to hospital care to skilled nursing to home care, and then released back home again. And that about every 4 months that cycle was happening. So again, you know, this data must exist out there, which I guess is partially the reason why the insurance companies are just being so staunch about this. You know, I'm saying that they're just not going to pay it. I mean, really, what choice do I have? If the hospital says you owe it, the insurance company says you owe it, and it's between the two of them.
Dr. Stolp, is this going to be more of what we're going to hear about in the future?
I think it'll be less.
You think it'll be less?
Absolutely.
Okay.
Number one, I commend Dave for figuring out how to solve the problem and knocking on the right doors, because there are advocacy programs out there that will deal with injustice, and that's just plain old injustice. The concept, number one, in the Affordable Care Act, there is something called pay for performance. If a case of, let's say, a cholecystectomy, a gallbladder disease, if a gallbladder disease patient has a complication, let's say an infection, due to the surgery that was contracted at the time of surgery, that will not be covered any longer. That's something that is now borne by the hospital in which that infection was contracted. And so complications, delays are to be borne by the hospital in those situations, aligning the reimbursement with the goal of the healthcare system. To me, that is, if we keep that as the golden rule, if we can construct a system whereby reimbursement is in alignment with the best interests of the patient, the best wellness interests of the patient, right, we don't have to worry because the system will take care of itself. But right now, paying for procedures, paying according to hospital days encourages, in the past, and this has evolved now over the last 10 years to not be quite so true, but to reimburse for procedures encourages more and more procedures and more lab work. An example, the Intermountain Healthcare Program is a physician-sponsored cooperative insurance program in the Middle States, Idaho, Utah, Montana, I think, that found that they had a very high rate of infants, newborns, that were intubated, which they were paid for. Anytime an infant is intubated and placed in an intensive care nursery, that's income to the system, okay? But it's not good for the patient. And they looked at a way of revising their newborn management and their management of respiratory distress in newborns such that they cut in half their numbers of intubations in infants in all of those states, which decreased initially their reimbursement, but allowed them to shift their attention to other items that improved their health elsewhere and gave them an incredible, made them incredibly desirable to the entire healthcare system.
I think it's wonderful that they're actually making the effort to really look at the value of the healthcare services as it relates to the wellness of the patient. I mean, that's got to be a huge step forward. But I question in the back of my mind, and I'll make this big leap out there, and that is, who is the ones that are really doing the decisions on this? Who are the panels that are really going to decide this? Because this can go down a slippery slope also of, if there's not the right level of trained people to actually, number one, everything from collecting the data in, garbage in, garbage out, if they're not really training people properly, if there are people actively trying to sabotage the system, if the information is not pulled correctly, if it's not reported on regularly, if it's not monitored regularly, if they don't take actions from those regularly, then we wind up with another quagmire that may not be any better than we have now. Now, I hope that doesn't happen, but the leap I'm saying here is, who's actually going to be the people making those choices?
In this particular case, as I mentioned, this was a physician-supervised system, a scientist-supervised system, including epidemiologists, and a number of those with sophisticated ability to analyze data. So, and evidently it's working, because, again, they decreased significantly the number of infants that were intubated. So I agree with you. Unfortunately, gathering that data requires a more sophisticated system for data collection, and that's where you get into the electronic health records that you discussed at your last meeting. That's one of the ideas, is to gather that information in that fashion, so it can be accurate and relied upon. I agree 100% with what you say.
Okay. Well, gentlemen, unfortunately, we have come to the point, we have to kind of wrap this up, but what's the hope for people in our region? With what can you predict, honestly, just kind of a closing comment, and John, I'll let you close with that too, that you're going to see in the healthcare business?
I'm hoping that we will find some of these programs redirecting our efforts towards where they can do the most good. We know that substance abuse, alcohol, tobacco, drugs, prescription drugs, mental health care is a critical issue. Our analysis that you'll be reading about soon. And with the new requirement that those specifically receive attention and are paid for, I'm hoping that for Tuolumne County that will bear fruit. I hope that some of our uninsured will have access, and that we will be able to prevent folks from using the system by promoting wellness. And I think that's within our reach. To what extent, it won't be a smooth road. We can bet on it being bumpy, but speak up. I would encourage your listenership to speak up when they run into problems, just as Dave did.
Good, John. Your final comment.
John, excuse me.
Yeah.
Sorry.
Well, the final comments, I guess, would just say it is a big hope out there that this particular effort by the government to try and move us towards real data that will increase the quality of health for people, and particularly being the age I am now, and I think I can look around the room and say the age for all of us, it becomes more and more of an important factor as we get older, because we tend to use these medical services much more. So I'm pleased to see that we're actually headed down that path. I think I'm just concerned over the data and being able to take action on that data, because I just believe in taking action and not treading water. And I think that'll be the key to all of this, that we really make these choices and move forward with them.
Well, thank you, John. Dr. Stoltz, it's been our pleasure to present this. And on behalf of Gold Rush News, I'm your host, Karl Dambacher, with Dambacher's Daily Debate. Thank you for joining us.